So I'd like to welcome everyone to the 7th webinar of the 2025 series, Methadone Prescribing, the Basics, with Katie Dunham and Meldon Kahan. I'm Laurie Smith. I am the Administrative Coordinator for the Medify team, and I am here tonight in lieu of Dr. Jennifer Wyman. She's the webinar scientific chair and the usual moderator, but she couldn't be here, so I am here in her place. So let's start with our land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. Medify is located in Toronto, and that's where I live as well, on the ancestral homelands of the Huron-Wendat, the Anishinaabe, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons. This is Dish with One Spoon Treaty territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich culture and traditional practices of the ancestors. And we invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So as we get started, there's just a couple of little housekeeping things to go over. Those of you who have been here before know that we usually encourage you to add your questions to the chat, but we're trying something different this time, and it's through Mentimeter. So as the presentation slides get put on the screen, you will see a QR code, either that or the website address for Mentimeter, and that is what we encourage you to use to ask questions. And what will happen is your comments and questions will be compiled, and then at the end of the presentation, Katie will put them up on the screen and they will be addressed. Now, if you're not comfortable with that, by all means, please do use the chat box if that's what you prefer. And you're also welcome to raise your hand to be unmuted to speak in the question and answer period. As always, we have a session evaluation that we would love you to fill out near the end of the session. There should be a link that comes up in the chat, but if not, you should get one from Zoom. And then finally, the accreditation credits are on the screen for those who can claim them: College of Family Physicians of Canada, Main Pro, and the Royal College of Physicians. Thank you to our 2025 webinar series committee members. Jennifer Wyman, of course, the chair, is not here. And I don't think anyone else is, but we do appreciate their contributions. And finally, the last couple, let's just pull us up here. The last few webinars of this season, tonight is Methadone 1, October 22nd is Methadone 2, Beyond the Basics, followed by infectious disease considerations in November, and geriatric considerations for older adults with SUDs in December. All right. So with that, I have the great pleasure of introducing our presenters for tonight. I'll start with Katie. Katie Dunham is a primary care nurse practitioner with a background in global humanitarian aid, emergency nursing, primary care, rapid access addiction medicine, withdrawal management in a community-based lived-in setting, and virtual addictions care through the Digital Front Door platform. She acts as nurse practitioner lead for Stonehenge Therapeutic Community Rapid Access Addiction Medicine, and is faculty at the University of Toronto Bloomberg School of Nursing. She is passionate about expanding access to substance-related care through education and optimizing existing care pathways through community partnerships. And I also have to mention that Katie is Medify's nursing educator extraordinaire. Next, we have Dr. Mel Kahan. He is Medical Director of Medify. Dr. Kahan has written a number of peer-reviewed articles on addiction and has been a principal or co-principal investigator on several randomized trials and observational studies. He has been extensively involved in policy and advocacy. He has helped write several guidelines on opioid agonist treatment and opioid prescribing for chronic pain, and has co-authored several handbooks and guidance documents, including Methadone Treatment for People Who Use Fentanyl, Recommendations 2021, and hot off the press, just today, as a matter of fact, we have the release of a new Medify guideline, Methadone as Opioid Agonist Therapy, Guidelines for Prescribers. That's an update, and both Mel and Katie were contributors to that guideline. Mel's main interest is the integration of addiction medicine into primary care, emergency departments, and hospital units. He has 5 grandchildren who like to remind him how old and how slow he is. So that is our introductions, and let's get going. Katie, were you able to put the links in the chat?
The links are in the chat. Congratulations, everyone that is here, because now you are the first to get a peek at these new releases. So please feel free to explore them as we go.
Okay, so let's just get this on the screen. Hello? Okay.
All right. Disclosure, conflict of interest. I received an honorarium from Indivior, the makers of buprenorphine and Suboxone and Sublocade, for a presentation I gave on methadone. Next slide. So just before I go into this, I think that methadone has been around for like at least 80 years. It's the mainstay of treatment for opiate use disorder. It remains, even though newer modalities have come in, like buprenorphine sublingual and buprenorphine extended release injection, methadone remains an essential component of treatment. So this is just a brief overview of methadone prescribing to demystify it, to show how to prescribe it safely and effectively. We're going to have another webinar in a month on perhaps more complex or advanced issues around methadone prescribing, but this webinar gives a very good start. And the guideline that Lori mentioned is written from the perspective for new prescribers. So it really does cover the basics of methadone prescribing in more detail than is given in this talk. So I just strongly encourage you to look at that. So the learning objectives, we're going to discuss the benefits and risks of methadone compared to buprenorphine. So in Ontario right now, pretty well all RAM clinics are comfortable with prescribing buprenorphine, but not all are comfortable with methadone. Describe a protocol for safely prescribing methadone, including initial dose and dose titration and optimal dose. Describe patient assessment, lab tests, harm reduction interventions, and take-home doses. Next slide. This is the QR code that Lori mentioned at the beginning. I don't know, Katie, should we say anything more about this now, or is this clear
You're
enough?
doing great. Anyone that wants to can open your cameras for that QR code and get it lined up now, or use the link and the code there if you'd like to. You are welcome to use the chat as well for comments, but we will try to compile all of the questions on the Mentimeter so everyone can see them anonymously afterwards.
And Sarah gave a link as well in the chat. Pharmacology of methadone. Next slide. Methadone is an unusual drug in that it's a very potent full mu agonist. So it's similar to hydromorphone and morphine and oxycodone, etc. What makes it unusual is that it's got a long and variable half-life. So at the beginning of treatment, its half-life is really long, up to 5 days. That's extraordinarily long. And then as people use it more, enzymes in the liver get induced and the half-life declines to somewhat less than a day. So that poses a danger if methadone at the beginning of treatment, before patients are fully tolerant to it, they can take a dose on Monday that is barely adequate to relieve withdrawal symptoms, and they could be in the intensive care unit by Friday because the methadone accumulates in the serum because of the long half-life. So 1 milligram of methadone is the analgesic equivalent of around 8 milligrams of morphine, so it's pretty strong. Next slide. And methadone is dispensed in bottles of liquid and that are colored and flavored, and this is to prevent injection opiate use. And here's a nice table of the different kind of formulations of methadone, Betadol D, Sandoz, Methadose, etc. So early in treatment, methadone is dispensed daily under the observation of a pharmacist. And this is to prevent the patient from taking more than is prescribed, which can be dangerous for them, or from selling the methadone or giving it to other people, which can be dangerous for the public and for their colleagues and friends. Take-home doses are gradually introduced when the clinician feels it's safe to do so. Now, methadone is also available as tablets, but these are rarely prescribed. They're not covered under ODSB. They're not used for opiate use disorder because they can be easily crushed up and injected, but they are used for severe chronic pain. Next slide. Adverse effects are the same as other opiates: sedation, fatigue, sleep apnea, constipation, nausea. One unusual side effect is that at very high doses, and if other risk factors are present, methadone can prolong the QT interval, which can rarely cause torsade de pointes, and which is a ventricular arrhythmia, and we'll be talking about that a bit later. Now, methadone is very potent and can cause respiratory suppression and death, especially in the first couple of weeks of treatment before the patient is tolerant to it, or if diverted methadone is used by someone who has never taken it before. Methadone overdose has the exact opposite clinical features of fentanyl overdose. Someone takes fentanyl and they stop breathing and collapse pretty well right away. But with methadone, the onset is very gradual, and it can be sometimes hard to notice. The patient is nodding off, appearing to fall asleep. They can appear relatively alert when they're engaged in conversation, but when they lie down to go for a nap or whatever, they can stop breathing and die. Next slide. Methadone has been extensively evaluated in multiple controlled trials and systematic reviews and observational studies, and it's been shown that people who are heroin users or fentanyl users or prescription opiate users, that methadone reduces overdose, reduces total mortality, reduces hospitalizations from infections and other causes, and improves mood and daily function. And it markedly reduces overdose risk even in people who use fentanyl. It does this by reducing the amount and frequency of use. If patients are not having cravings and if they're not going into withdrawal, they're going to use less. And also by building up tolerance to opiate-induced respiratory suppression. So even if they do take fentanyl, they're less likely to stop breathing because they're tolerant to the respiratory center in the brain has built up tolerance. Next slide. Safety and effectiveness of methadone versus sublingual buprenorphine. Next slide. So methadone has consistently been shown to be more effective than sublingual buprenorphine at retaining patients in treatment. This is controlled trials and observational studies and meta-analyses. This is probably because methadone is more potent than buprenorphine. Buprenorphine is a partial agonist with a ceiling effect, whereas methadone is a potent full mu agonist. Methadone is so that means that it's more effective at relieving withdrawal symptoms and cravings, especially in high dose, high potency opiate users. Also, withdrawal from methadone may be more intense than buprenorphine, which is a way of keeping patients in treatment. Next slide. However, buprenorphine is definitely much less likely to cause a fatal overdose than methadone. In the US in 2020, there were 52 deaths per month from overdose with methadone present in the serum and no other opiates. So that's a lot, 620 deaths per year. Most of those who died were people who took diverted methadone. Deaths with buprenorphine, but no other opiates present, is actually quite rare. And that's because buprenorphine is a partial opiate agonist that does not fully act on the respiratory center. Next slide. Methadone may be more likely to cause side effects than buprenorphine, including sedation and sexual dysfunction and cardiac arrhythmia. Next slide. So what about extended release buprenorphine? Whatever I said about sublingual buprenorphine cannot be applied to extended release buprenorphine. It's a very different drug in many ways. Buprenorphine produces a much higher and more constant serum level of buprenorphine than does sublingual buprenorphine, and that means that it may be more effective at relieving withdrawal symptoms and retaining patients in treatment. Certainly more effective than sublingual buprenorphine. We don't really know how it compares to methadone. There are RCTs underway comparing the two directly, but early preliminary studies are promising. One study done here in London by Ken Lee showed that buprenorphine extended release had people who took that had fewer overdose events than methadone. But that study did not necessarily control for the severity of people who were on methadone versus buprenorphine extended release. There was a pragmatic RCT that showed that buprenorphine extended release was superior to sublingual, but there were only a few patients on methadone, so we can't really say. So it's an open question, but certainly extended release looks very promising. Next slide. Now, methadone has a sort of stigma or fear about it, and that's not surprising because it is a medication with a narrow therapeutic window. People can die or get serious overdoses if it's not prescribed carefully. So, however, it remains essential in the treatment of opiate use disorder. So we strongly encourage you to get familiar with it. One good thing is to have a mentor, someone you can call if you have questions about it. If you're a new prescriber, the problem with methadone is that if you're starting to prescribe it in a RAM clinic, there may be none of your colleagues have any experience with it either. So that makes it much harder. Follow the dosing guidelines. All of them, including the one we just produced, were written with patient safety paramount in mind. So if you follow them, you should be fine. Remember that dose titration is based on the patient's level of risk for methadone toxicity. And this risk varies greatly from, an older person with COPD who's using too much codeine versus a young, otherwise healthy fentanyl user. Remember keeping in mind the balance of risks and benefits. Fentanyl is, maybe that's not quite true to say it's far more potent than methadone, but fentanyl is far more potent than heroin or hydromorphone or any other opiate. So fentanyl users generally have a high opiate tolerance, meaning that they're at lower risk for methadone toxicity. And also remember that if you need to titrate to keep the patient in treatment. If you titrate too cautiously, that risks treatment dropout, and that itself puts the patient at risk of serious harm from continuing to use fentanyl. So bottom line, all RAM clinicians should feel comfortable prescribing methadone when indicated. Next slide. Criteria for choosing methadone over buprenorphine. Next slide. Patient preference is a key central criteria. Patients often have very strong feelings about which they prefer. Many of them have tried methadone and or buprenorphine, so they have strong preferences. It's better to go with these preferences because you want the patient to be expecting a good outcome. Next slide. Of course, related to patient preference is their experience with opiate agonist treatment. If the patient has previously done well on methadone and reduced their high-risk opiate use and overdoses, and et cetera, and they stop methadone treatment for whatever reason, and or if they didn't do well on buprenorphine, they weren't able to get to a therapeutic dose, they repeatedly missed doses, that would be a sign that methadone should be chosen. Next slide. Risk of methadone toxicity is an important criteria. So the risk factors include heavy alcohol use, benzodiazepine use, gabapentin use. Patients who use methadone and combine it with alcohol or benzos or gabapentin are at much higher risk of overdose death. Or if they have a low opiate tolerance, that means they're maybe just using Percocet, that would be a sign that you should consider buprenorphine. Or if they have medical conditions such as respiratory impairment like COPD, or they're a frail elderly patient, those would all be signs that buprenorphine is preferred because it's safer. If methadone is used, it should be titrated carefully with a lower initial dose. Next slide. Higher risk for treatment dropout might be an indication for using methadone over sublingual buprenorphine. That is, if they're using fentanyl or heroin, if they have concurrent mental illness, if they're homeless, if they're heavy user of other substances like crystal meth. Crystal meth is especially a factor in treatment dropout for methadone treatment. So that might be an indication for using methadone. Next slide. Yeah, I think I talked about that. Higher risk of methadone toxicity. Next slide. Difficulty attending the pharmacy daily. This is a very important factor in choosing methadone versus buprenorphine. Methadone is generally dispensed daily under observation for at least the first 4 weeks of treatment, and this is done to reduce the risk of diversion and overdose death. However, there are patients who are likely to miss doses at the pharmacy. If they have concurrent mental illness, if they're homeless, or they lack transportation, or if they're using crystal meth. And if patients miss several days in a row, the clinician has to lower the dose, which I'll talk about later. And this means the dose is subtherapeutic and more likely to lead to a treatment dropout. Youth also tend to have difficulty with daily pharmacy visits. So buprenorphine is preferred in these patients, safer to give carry doses early in treatment with buprenorphine. The injectable is even better because the injection is only once every 28 days or so, and that completely removes the need for daily dosing. Next slide. So getting on to methadone dosing. It depends again on the patient's risk of toxicity and the amount and potency of their opiate use. As I mentioned, these are the risk factors for methadone toxicity. So someone at higher risk, for example, if they're a lower opiate tolerance or they're using benzos, the initial dose would be 10 to 25 milligrams. 10 milligrams if they are at higher risk and 25 milligrams if it's moderate risk. The standard initial dose with no known risks is 30 milligrams. However, the BCCSU, that's the British Columbia Center for Substance Use, recommends 40 milligrams as an initial dose in fentanyl users. And our new methadone Medify guidelines recommend up to 50 milligrams for high dose fentanyl users. That's at least 1 gram per day in people who are known to your clinic. And that's based on the US recommendations that it's safe to give up to 50 milligrams. Next slide. Titration. So with each dose increase, the patient should experience longer and more complete resolution of withdrawal symptoms and cravings. So if a patient says, well, you gave me 30 milligrams and I only felt good for about an hour or so after, well, at least you're on the right track. The dose should be increased by no more than 5 to 15 milligrams every 3 to 5 days to avoid bioaccumulation. If you can increase by 15 milligrams if the patient is still very early on and they're having marked withdrawal symptoms and they're at lower risk of toxicity. Increase a bit slower, 5 to 10 milligrams if the patient is getting substantial relief for most of the day from their withdrawal symptoms, or if they're at higher risk of toxicity. You can increase every 3 to 4 days, if possible, during the first couple of weeks until the patient is starting to get substantial relief and their opiate use has declined. Next slide. The optimal dose provides with relief, almost complete or mainly relief of withdrawal symptoms and cravings for up to 24 hours with a marked reduction in opiate use and with minimal side effects, particularly sedation. The optimal dose is, generally speaking, in the range of 80 to 120 milligrams a day. That's also the dose which is shown to be protective against overdose. It can take several weeks to reach the optimal dose, but if you start with higher initial doses for fentanyl users, 40 milligrams or even 50 milligrams, that will shorten the time to reach the optimal dose. Next slide. Slow release oral morphine. This can be, or Cadian as it's often called, this can be used as a sole opiate agonist treatment or in combination with methadone for people who use fentanyl or heroin. And the rationale is that people who use fentanyl have very high tolerance to opiates, and that means that methadone may provide little relief of withdrawal symptoms and cravings until a dose of 80 milligrams or so is reached. And that will cause some patients to drop out of treatment in the first couple of weeks before they reach an effective dose. Slow release oral morphine does not accumulate in the serum the way methadone does, and it reaches a peak in the serum about 10 hours after dosing as the methadone is wearing off. So adding SRAM to methadone can help retain patients in treatment and provide them relief in the early days. So the initial dose of SRAM for heavy fentanyl users is 200 to 300 milligrams, and it can be titrated by 1 to 200 milligrams every 2 to 3 days. There's no clear guidelines on what to do after the optimal dose of methadone is reached. You could, at that point, taper down the SRAM or maintain the SRAM if the patient feels that it is benefiting them. Next slide. Wraparound care or additional care that accompanies the dose titration assessment. Assessment is started, of course, at the first visit where you want to collect enough information to make a decision about methadone, but you may not complete all the assessment. You want to do it, though, in the first few visits. Type of opiate, frequency of use, route of delivery, injection, smoking versus oral, opiate-related problems, withdrawal, symptoms, overdoses, injection-related infections, legal difficulties, reason for use. Oh, I forgot time of last use is important. Whether it was an hour ago or 3 days ago, previous opiate agonist treatment experience. This is other substances used, including alcohol, meth, cocaine, benzos, prescribed medications, of course, underlying medical conditions, underlying psychiatric conditions and hospitalizations and social situation, housing, social supports, childcare, etc., and links with the healthcare system, including the family physician or nurse practitioner. Next slide. Lab tests include CBC and liver enzymes, hepatitis B and C, serology, HIV, VDRL to detect syphilis, urine HCG for pregnancy. And what you're trying to do is detect hepatitis C, which is very common and which can be treated in a REM clinic setting, and also detect opiate use because that will show elevated enzymes. You don't want to delay starting methadone pending assessment or laboratory tests. It's important to start it on the first visit if indicated, and that's because patients' motivation to enter treatment it changes from day to day. So you really want to get them engaged in treatment as quickly as possible. You do want to get an ECG if there's a family history of prolonged QT syndrome or sudden cardiac death. But the only lab tests that really should be obtained on the first visit is a urine drug screen. And that's because patients may tell you that they're using fentanyl, but they may not tell you that they haven't used in a week and they may have less tolerance to it. So you want to confirm their self-report by getting a urine drug screen that shows whether fentanyl and other opiates are present. Next slide. ECG should be requested once the dose starts to approach 80 or 100 milligrams or above, especially if the patient is at higher risk for arrhythmias. That includes previous heart surgery, structural heart disease, risk for electrolyte abnormalities if the patient's on diuretics or on drugs that prolong the QT interval. Next slide. Harm reduction, all patients should be given a take-home naloxone kit and explain its use because patients are at risk for overdose, especially in the first few weeks of treatment, and explain overdose prevention strategies. That includes always carrying a naloxone kit with you. Don't use alone. Even in your own house, there needs to be someone with you in the room. Don't mix opiates with alcohol or benzodiazepines. If you, especially because the purity of fentanyl may vary, use a test dose to make sure that it's not too strong. Also give patients a supply of clean needles or inhalation equipment and counsel them on their use because there's very good evidence that these clean needles and inhalation equipment reduce not only Hep C and HIV, but they also reduce infections like cellulitis and sepsis and so on related to injections. And there's some useful links there. Next slide. Counseling during early titration. This is more like coaching and encouraging the patient to remain in treatment. You want to say, well, okay, the delay of daily observed dosing is intrusive and a drag. You wake up in the morning and you're in withdrawal, and maybe you should just use instead, but it's temporary. If you feel you must use, try to use just enough to relieve withdrawal symptoms and cravings. Try to avoid sedating drugs like alcohol and benzos. And as you approach an optimal dose, this is the reward. If you can stick it out for a few weeks, you're going to feel a lot better. Your withdrawal symptoms and cravings will improve. Your sleep and energy will improve. Your mood and daily function will improve. So the emphasis is not, oh, you're addicted and you need to stop. It's if you take methadone, and you don't have to stop if you're on methadone, but if you do take methadone, you're going to use less. Your withdrawal symptoms will improve, and all these other good things will happen to you, and you'll feel better. Try to stay away from negative influences, drug dealers, other people that you use with, and spend time with family and friends if you can. Be patient. Don't be discouraged by setbacks. A lot of people have, okay, I'm going to never use again, and they use once a small amount and they say, oh, this methadone is not going to work. Try and give methadone a good try and hang in there. Next slide. Take-home doses. There is a dilemma with methadone. Take-home doses are dangerous early in treatment. They can be diverted, putting methadone-naive patients at risk of overdose. And yet, if patients are never given take-home doses, they will drop out of treatment because going every day to the pharmacy when you're in withdrawal for an indefinite period is it's an unrealistic expectation. Evidence shows that the gradual introduction of take-home doses to patients who have reduced problematic substance use is the most effective policy for retaining patients in treatment while minimizing diversion. Next slide. The decision to prescribe carries is based on how long they've been on methadone, their ability to store methadone safely If they're living in a shelter, maybe it's not a good idea to give them large numbers of carries. Their stability, if they're actively suicidal or psychotic, giving them large take-home doses may be dangerous. Substance use, if they're using crystal meth or whatever, alcohol very heavily, they could misuse their methadone doses or sell them, and miss doses, of course, which I'll talk about later. Next slide. This is a very useful kind of a guide to making decisions about carries for clinicians. It was written in 2023 and it's available through the Medify website. It goes over the same things I just mentioned. Next slide. Carry schedule, we suggest daily for 4 weeks. After 4 weeks, up to 3 non-consecutive carries per week, such as Monday, Wednesday, and Friday, if the patient meets these criteria, and then increase by 1 carry per week every 2 to 4 weeks. And of course, you will need to make exceptions to the carry, what we used to call special carries, if based on the patient's work commitments, family commitments, health or family emergencies, difficulty attending the pharmacy, et cetera, et cetera. You have to be, flexible with patients because you don't want them to drop out of treatment. Next slide. Substance use, how do you verify substance use? Self-report should always be asked about, of course, and it should be verified at that clinical visit by point of care or drug screen, which may be done weekly at the beginning of treatment and once every month or 2 after that during office visits. So again, if they're using high risk substance use, that is, they're still using fentanyl daily and they're at risk for overdoses and impaired judgment and not functioning well, then they should probably continue to go daily to the pharmacy. If their substance use is still regular but is less and doesn't pose a safety risk and they're functioning pretty well okay, then they can have carries. And if they have no or non-problematic substance use, they can have up to 6 carries a week. Next slide. Missed doses. The problem is if the patient misses several days in a row, they lose their tolerance to methadone. And then if you put them back on their original methadone dose, they could have some degree of sedation and toxicity. So we recommend if 4 days in a row are missed, then reduce the dose by 50% while increasing rapidly up 10 milligrams per day for 3 days and then reassess. If 5 days in a row are missed, you should go back to the starting dose, which is 30 milligrams, and increase as needed by 10 to 15 milligrams every 3 to 5 days. Next slide. Now, methadone prescribing in RAM clinics. Next slide. The big challenge is the RAM clinics that have limited hours. And especially early in treatment, methadone patients and sometimes pharmacists need to contact the methadone prescriber urgently. For example, if the patient has missed several days in a row and the dose needs to be adjusted downwards, or if the patient missed their last appointment and needs a new script, and you need to fax it in, or if the patient urgently needs a take-home dose. And if the RAM clinic has very limited hours, it's difficult to manage these urgent script requests. Next slide. So what we suggest is if the patient shows up and methadone is indicated, we suggest starting methadone at the RAM clinic, because if you tell the patient to go to a different clinic, there's a high chance that they will simply not go and they will drop out of treatment, and you'll have missed an opportunity to engage them. Give them a longer script, e.g. a week, even if you want to see the patient in 3 days. And if this is a problem, these limited hours, transfer them to a community methadone clinic with longer hours and more coverage within the first few weeks of treatment. That's our suggestion. Next slide. Now I'm going to turn it over to Katie to address the questions and cases.
Perfect, thank you. And thanks everyone for that's submitting questions so far. We are receiving them and we will share them soon. So keep adding questions. I do see the questions in the chat here as well, and those are perfect. You can keep adding those. We'll address them as well. We're going to move on to cases next, Lori, if you want to go to the next slide when you're ready. For the cases, please feel free to participate. You're welcome to add comments, questions, or your expertise into the chat and the conversation as we go along. So the first case is of a 20-year-old who presents reporting Percocet and D8 use, about 1 to 3 pills at a time, about 2 to 3 times a day. Most days of the week, they're using it's oral use only, and they're sometimes crushing it. They also say they're using Xanax, but only when it's offered, a few times a month, maybe 1 to 2 pills at a time. They do use cannabis every day, smoked. They say they get it from a dispensary, and they're using cigarettes, about 5 to 8 cigarettes per day. They do report that they had an overdose a week ago. They needed 3 different Narcans. They did get CPR. They were brought to the emergency department, but they were discharged the same day. Their partner is actually on methadone, so they want to do the same thing and got on methadone. Their history includes generalized anxiety disorder and major depression. They have no meds currently, no allergies, and they do live with their partner in an apartment. So initial thoughts in terms of treatments for this person. I think, and you're welcome to add them to the chat box, please, if you want to join in along the way. The first thing you're going to be thinking about is which medication option you're going to be choosing. First and foremost, as Mel pointed out, is going to be patient preference. Keeping that in mind, this patient has a partner who's on methadone. They may therefore do really well also being on methadone, being able to share that experience, maybe choose the same pharmacy, be able to go together to the pharmacy when they need to do their dosing. So that could be a huge benefit for them that they already have that support system built into methadone. But the other side of this to consider is this person has a fairly low reported tolerance to opioids. But they're also reporting an overdose that happened with 3 Narcan needed from reported Percocet and D8s, although we know that Xanax and other substances have potentially been mixed in. So kind of highlighting the importance of getting that urine drug screen. I did see the question in the chat about, is it standard of care to get point of care urine drug screen? If you're an in-person care provider, I'm going to say yes, that is standard of care. You absolutely should be able to do that before you're starting an opioid agonist treatment, because it's really going to inform your conversations and your recommendations to the patient and their treatment choices ultimately. We're going to talk about virtual care because I know that can be different, and that is the setting that I work in as well, in virtual world. But for this person, they actually do have reported low opioid tolerance, fairly low, although we have Xanax, so you'd really want to get that urine drug screen. This person has a partner that's on methadone, so they requested it, which is great to consider in terms of preference, but that doesn't actually mean that they know what other options are available, and even their partner may never have heard of buprenorphine or Suboxone and know that it could be potentially a better option for them longer term, considering their age, considering their use, not having to go to the pharmacy every day. There's no reason to think that it couldn't be an option for this person, depending on the goals that they stated in your visit. So it's not wrong, even though the patient says, I want methadone, to say, hey, have you heard of Suboxone? Do you want to talk about it and see if that's an option for you? I've had clients that have chosen it in the past and actually brought in their partners to then say, I didn't know about this either, and I'd like to switch on to it. So really following their choices in the end and the route that they want to go. If this person was going to be starting methadone, you are probably going to be looking at the mid to standard start of anywhere from your 10 to 30 milligrams, and kind of building up slowly as you go along with your typical dose increases. You're, of course, going to be thinking about your intake questions and trying to get labs and ECG. This person was just in hospital, so if you have access to hospital records, you can try to grab those or request them. And if not, you really do want to request labs and ECG, but don't, like Mel has highlighted again, don't wait to get those back before you start treatment. Get treatment and just continue to recommend those along the way. Okay, let's go on to the next case, maybe, Lori. Thank you so much. Okay, so this next one is a 24-year-old patient who's been using fentanyl for the last year, IV and smoked, and reports at least 2 to 3 grams of fentanyl use per day. They have no reported overdoses or poisonings. They do report occasional alcohol use, no purposeful benzo use, but they of course suspect that it's in their fentanyl. And they're looking to decrease, but they're not quite sure they want to stop their fentanyl just yet. Any comments in the chat in terms of therapy route you would want to go with, starting doses, considerations for this person? Mel, yeah, go for it.
Oh, sorry. I just want to point out that it is not hard to switch from sublingual buprenorphine to methadone. It's very hard to switch the other way. But going from sublingual buprenorphine to methadone is easy. So if, for example, in this case, you decided to go with sublingual buprenorphine and it wasn't working, you couldn't get them on it or whatever, methadone is always an option. So keep that on. The worst thing is to use Suboxone or methadone and just stick with it even though the patient isn't doing well. Remember, we now have four options: sublingual, buprenorphine, extended release, methadone, and slow release oral morphine.
That is such a good point. Thanks for pointing that one out, Mel, for sure. And for this person, like Mel said, it's really easy to get on methadone, even if you're already on buprenorphine. And this person doesn't want to stop use. Oh, if there's another hand up, you're welcome to jump in. If not, I'll keep going. So this person they're telling you up front that I'm not ready to quite stop using yet. And that means that methadone is just really easy to start in this client. You really can start methadone at any time. You don't want to start it while someone is intoxicated or sedated. But outside of that, outside of having that concern at the office, or at the pharmacy, you're pretty much good to get started with methadone if it's appropriate for all other reasons that you've done through your intake. So this could be a good option for this person, especially since they are reporting a high level of use for tolerance with IV and smoked fentanyl 2 to 3 grams per day. The missing pieces from this case study, of course, are we don't know if they've been on methadone or any treatments in the past. So because of their level of use, not knowing anything about their risk, let's say they have low risk for toxicity at 24 years old, you're going to be looking at least a 30 milligram starting dose. If they'd been, you potentially could consider going up to 40 milligrams, given that they have that higher level of use if they don't have a risk of toxicity. If they had been on methadone before, really the next Beyond Basics webinar is going to talk more about when you would be considering potentially even higher dose starts of 50 milligrams. Let's say this person reported that they were actually on methadone, 120 milligrams 2 weeks ago, but they ended up in correction, so it was stopped, and they're just coming in to get restarted. That's a person that you may have a lot more confidence starting on a higher dose of methadone, like 50 milligrams, or at least the 40 milligrams if they came in. Always good. This person is already kind of telling you that they suspect other things are in the substances that they're using. So a really good reason to encourage getting that urine drug screen and sending it for chromatography to just confirm the presence of what's in their system. There's no point in us doing the testing if we can't really talk to them about it and go through it. For any methadone start, I do think it's really important that you go over upfront what carry doses will or won't look like for this person. For instance, this person is saying they may not be ready to change or decrease or they want to decrease, but they're not maybe ready to stop their use yet. So would you be giving full carry doses to someone that may still be continuing to use fentanyl through the IV route? Maybe not. You may want to stop at 3 non-consecutive carries. Thank you in the chat. You may want to go with 3 non-consecutive carries if someone's continuing IV use of fentanyl. And that could bring up a harm reduction conversation in terms of, is there an option where they want to move from IV to just smoked and then continuing those conversations from there. Other points, I guess, to just bring up that we don't have in this case study is that this would be a limited intake for this particular person. You'd want to explore other considerations around housing, around relationships, income, legal involvement, and pharmacy access, their mobility, because that's really going to influence as well what choice you're ultimately going to help them make. I just want to share a side case from this one, or question of, if this case number 2 came in to your clinic virtually, how would that change any of your considerations for what you might do for that person? Especially if they're looking for methadone treatment, because I know that's a common consideration that comes up. I will share a similar case that I had virtually present to me, which was a person who came in saying they'd been on methadone before. They were using fentanyl daily, at least 5 points or more per day, and they just wanted a methadone restart. No problem. This all seems very straightforward. You've been on it before. Let's get things going. But through more conversation with the person, they reported that their previous methadone dose was 20 milligrams. So that's pretty low for someone that was using fentanyl, and I didn't have any reasons that they were at high risk for toxicity. So that didn't quite add up already. That was enough for me to initially say, okay, let's pause. I'm on a virtual screen. I can't get a urine drug screen to confirm your fentanyl use. And you're saying you responded well to 20 milligrams of methadone. The story is not quite straight. So it is okay, I think, sometimes to say that you can't be everything to everyone. And I let that person know we weren't going to start methadone that day. If that ultimately was the choice that they wanted, I could contact their previous prescribers and pharmacy and just find out more of the reasoning. And they could come back in a couple of days once I had that information and go ahead with a methadone start. Or we could start pretty low dose methadone that day if that's really what they wanted to do. Interestingly, what actually happened with that case is the person had never heard of buprenorphine before. So they were actually thrilled to hear there could be another option and decided that they wanted to go that route instead. So just highlighting that there are multiple options for people these days. And just because someone says they want something, they still may never have been told about all the options they have available, since it has been changing so rapidly over the last number of years. Okay, let's go to case 3. Thanks, Lori. Okay, so this is a 52-year-old male who's already on methadone, 80 milligrams once daily, observed dosing for 2 months. They have ongoing fentanyl use daily, smoked only a few points per day. He misses his dose a few times per week, but no more than 2 consecutive missed doses. He hasn't come in for an assessment since his first 3 weeks in treatment. So you haven't seen him for many, many weeks at this point. The pharmacy does communicate when he misses doses, though, and the pharmacy continues to request prescription renewals each week. Has anyone had this patient before, and what are your considerations for management? So we have a wonderful pharmacist. Good question. I'll get to that one as well. Thanks for the question in the chat. So we have a wonderful pharmacist in this case, which is great. So maybe we could take advantage of that. They're communicating missed doses regularly, and they're sending prescription renewal requests. Maybe we can talk to the pharmacist and see, one, how the patient's doing, and is there a way that you can talk to the patient when they go in to pick up their medication? Are they able to put them on the phone at the very least, if not have a room where you could talk to them on a screen to actually do your assessment that way moving forward? That could give you all the answers that you need. So working with the pharmacist could be a huge benefit. If you can't get that, can you at least get the information from the pharmacist about, is the patient having a hard time accessing the clinic? Is it the hours? Is it the location? And if so, again, we don't have to be everything to everyone. Is there another clinic that we might be able to recommend a transfer of care to so that they actually could attend appointments? Because if your patient is on 80 milligrams and it's working well and covering their withdrawal entirely, then that is fantastic. But that might not be the case. In fact, it may be that this patient has no problem missing doses because they actually don't find their dose that effective. So although maybe a little controversial, one route for management is actually when you're talking to the pharmacist to see if they find this isn't effective, you could consider a dose increase to keep them in treatment, encouraging them to come back to the office if you're able to get that assessment with the pharmacist's assistance. If, on the other hand, this is just ongoing, the patient is not coming to see you and they're missing some doses along the way, and you feel like you ultimately have to discontinue care. Mel spoke about this in the presentation, but we don't want to be cutting patients off of their methadone altogether. You could consider slowly decreasing your methadone by maybe 5 milligrams every week. And at some point, the patient is going to feel it if they did feel their methadone was effective. Hopefully, that will draw them back into the clinic for an assessment and to get restarted. Or you would just continue to taper until they stop showing up or they're off of methadone altogether. So that would be the worst case outcome. But it is a real scenario that, of course, we all have come up when people just don't come back in for their assessments. and you want to present a harm reduction forward-facing approach in terms of great job being on the medication, but we do need to see you at some point as well. Okay, next case. So this is the last one we'll present before our questions. This is a 44-year-old male patient on 150 milligrams of methadone once daily for 3 years. So pretty long time that they've been on 150 milligrams. They have a history of fentanyl use and crystal methamphetamine. They returned to use of crystal meth and occasional benzos about 2 months ago after a longer period of abstinence. They report feeling withdrawal symptoms now, and they want a dose increase of their methadone. Their history includes PTSD, anxiety, depression, and borderline. Their allergies include penicillin reported as a child. Their meds are venlafaxine 150 once daily and prazosin 2 milligrams before bed. Their labs were last done a year ago, all within normal limits, but there's no ECG on file. Any considerations for this one? Yeah, need an ECG is a great point. So yes, we need that for sure. One, that they're on such a high dose, they really should have an ECG. If you can get one, you're not going to stop treatment if it doesn't happen. You could continue to increase the dose slightly to the patient's request without the ECG as well, but you're going to continue to recommend it because it is going to be best to have that on file, especially considering that they do have another QT prolonging med of some risk, venlafaxine. We actually have in our recommendations, you'll find a link to a really good website that can talk to you more about QT medications, QT prolonging medications, and the risk level there. So you can suss that one out, or we can share it afterwards in the chat. So definitely you want to get that ECG for sure. Other considerations is that this patient was on methadone for 3 years before they reported withdrawal symptoms, but they didn't report a return to opioids. They reported using stimulants and benzos. So if they're going through withdrawal of anything, is it going to be more methadone that's going to be the fix for this patient's symptoms that they're having? Potentially not. So you really want to suss out what their withdrawal symptoms are and what they were using, and give consideration to whether the dose increase is beneficial or not in that moment if you're needing to address something else. Sometimes the question has come in, is there a max dosing of methadone? The quick answer is no, there's no max dosing. It's always going to be the conversation of benefits versus side effects. Because yes, these are opioids and side effects are real and patients could begin to experience those along the way. So always wanting to just monitor for that. If you did decide to go ahead with the methadone dose increase to see if it helped them, it wouldn't be a wrong choice. You would just want to do it a little bit slower and cautiously and monitor to see if it actually was helping them or if you were barking up the wrong tree. So something like a 5 to 10 milligram increase. Okay, so let's go on to the next slide, please. We have quite a bit of time, which is fantastic. And we have a list of common questions that many of you have submitted to us beforehand. I think we're going to go through those first. Please use the QR code in the link and the chat box to continue. Actually, Lori, can you go back to screen sharing? Use the QR code in the link to keep submitting your questions, and we will get to those, but I think I'm going to go through our common questions and answers first to see if that addresses some more of what you had told me through chats you wanted to hear. It is about slide 49, Lori. Okay, perfect. Thank you so much. So these are some of the common questions you've submitted, including what if a patient wants you to choose their OAT for them? If it's not fentanyl, how do I figure out my methadone starting dose? When do I repeat my labs and my ECG? If I start both methadone and SROM, how do I titrate both? And can I titrate methadone without seeing the patient? How do I manage the common side effects that come up for methadone? Next slide. Perfect, thank you. So let's start with, oh, we lost it, but that's okay. You got it, that'll work. I mean, that's fine there. That's okay, thank you. So let's start with what if the patient wants you to choose their opioid agonist treatment? That's you really do want to see what their preference is. And their preference might not be, I want methadone or I want buprenorphine. It might be, I don't want to go to the pharmacy all the time, or I don't want to come and see you more than once a month. And that's going to help guide your decisions, of course, as well, but always taking their patient preference into consideration as much as possible. Next up is going to be tolerance. You're going to think about the opioids that they're using, the route, the frequency, their risks for toxicity, which I have in just a slide from here, so you can see those again highlighted, which include, if they are using sedatives, things like alcohol, benzos, or gabapentinoids, their age and any frailty that's added into that. Respiratory concerns like sleep apnea and COPD would be things, again, you'd want to steer away from methadone if there was consideration for other options. Accessibility, pharmacy location, hours, if they deliver, if they have transportation, or what their mobility level is like, and their history of opioid agonist treatment if they've been on it, what hasn't worked before. And that includes someone that comes in repeatedly saying, for example, I want methadone, I want methadone, I want methadone, and they continue to say it visit after visit after visit, even though all you're doing is restarting them over and over and over again. Even though they are requesting it and it's their preference, that may be someone that you might want to steer to look at a different option to see if there's going to be a different outcome for them. Pointing back to what Mel highlighted, that it's a lot easier to go from buprenorphine to methadone than vice versa. We do have an opioid agonist treatment decision aid document that's pretty brilliant. So I've included the link on the slide. We'll put it in the chat for you if you want to go through that. And that can help you and your patients kind of make that decision of what OAT is best. Next slide. Okay, how do I figure out my starting dose? Thanks, Sarah. That's really going to come from two major considerations. It's going to be tolerance and it's going to be risk of toxicity. So I put the risks of toxicity on here. These are all in our plain language summary and our guidance document multiple times. But the higher risks for toxicity are going to include advanced age, frailty included, significant alcohol or benzo use that causes intoxication or sedation, advanced COPD, severe liver dysfunction, recent start of sedating medications, or interruptions in their opioid use that resulted in a loss of tolerance. So someone that hasn't used, let's say again, corrections, for instance, they've just been away from opioids. Maybe corrections isn't the best example for that. Okay, then from high risk, there is a risk. It's not high risk, but we know that there's a risk of toxicity. So that would include things like a moderate consumption of alcohol or benzos, concurrent use of medications that are sedating or interact with methadone by prolonging the half-life, someone that does have sleep apnea, and someone that has liver dysfunction, it's just not severe. Someone with no major toxicity risk factors, have no concurrent health conditions, really no other substance use, and no medications that are going to cause interactions. Next slide. Thank you. So the other consideration is their tolerance. This is really mapped out well in the guidance document, but just to put it on the screen here, two different ways of thinking about it. We have really divided it into a couple different categories thinking about your starting dose. So if someone has a lower tolerance and or high risk of toxicity, you have a pretty low starting dose of typically 5 to 10 milligrams, or really you're trying to encourage buprenorphine for someone at that level of risk of methadone. If someone has a moderate tolerance and a risk of toxicity, that's going to be the midpoint of 10 to 20 milligrams. If someone's moderate tolerance with no risk, or if someone's high tolerance with just a little bit of risk, then you're looking at 20 to 30 milligrams. Kind of our standard, I guess, our other base. And these might be newer recommendations that are going to be talked about more at the next webinar. But if someone has high tolerance and no major risk factors, you could start up to 40 milligrams. And if someone has very high tolerance and no risk factors, and they have known experience with a higher dose of methadone at a steady state, you could consider pushing them to the 50 milligram starting dose. Next slide. As it was mapped out in the presentation, this can also be looked at as an initial dose for a patient at risk for toxicity and or low tolerance, falling somewhere between 5 and 25 milligrams. The standard initial dose being 30 milligrams. Someone that's using fentanyl might be considered for 40 milligrams, and someone using more than a gram of fentanyl with that regularly, with a history of methadone use known to the clinic, might be started on 50 milligrams. So lots of considerations, lots of documentation if you're going for those higher doses. Next slide. Okay, another common question is how or when do I repeat my labs and my ECG? We know that clients that end up on methadone can be with the clinic for longer periods of time. So is it enough to just have it done once and on file? In general, you want to try to repeat your labs and your ECG annually if you can, knowing that it's always hit or miss with certain patients. Of course, you want to try to get it done more often if someone has a health change or some of the risk change in their life. But you really want to focus on getting these repeated, specifically for patients that are on methadone 100 milligrams or greater. Someone with a structural heart disease, you want to get that ECG, previous heart surgery, and using drugs that prolong QT. So quick examples of antipsychotics, thinking of our stimulants, people that use stimulants, cocaine and amphetamine also increase that risk. And people that are at risk for electrolyte abnormalities, which include diuretic medications that a lot of people could be on. Next slide. If I start both methadone and SROM, how do I titrate these? So we're going to talk about this more at the next webinar as well, but assuming a patient is using fentanyl and is at a lower risk for methadone toxicity, you're going to be starting your methadone dose around 30 milligrams. And we do recommend you start no more than 30 milligrams if you're combining it with SROM or slow release oral morphine. Your SROM, if someone's using fentanyl, is probably going to start around 200 to 300 milligrams. The typical titration for the methadone is going to be the 5 to 15 milligram increase about every 3 to 5 days. You're going to try to get that up as quickly as you can to at least the 80 milligram mark. Whereas the SROM increases by 100 to 200 milligrams, and that's every 2 days because there's not the same bioaccumulation of that one. If we're saying that you need to see someone in office for every dose increase, that's going to be a lot of visits for this person if you're increasing both medications. So in the guidelines, you will see that there is the recommendation for people that aren't new to these medications to do one pre-planned dose increase, which works very well within the 7-day week. So let's say you're seeing them and you're going to increase your methadone dose that day or the next day. You may have a pre-planned Kahan increase 1 or 2 days later. And then they're going to see you back next week and you're going to do the methadone and have the Kahan increase. So those kind of tricks can kind of help to get someone feeling better a lot more quickly if you're only able to see them once a week. If you can bring them back more often, of course, that's a wonderful thing. Just not possible for everyone. Next slide, which really answers, I think, this one of, can I titrate the dose without seeing my patient? Yes, recommendation is not to do more than one pre-planned dose increase. Seeing the patient is always the preference if you can, and these should be saved for clients that aren't new to these medications. You're probably going to want to see someone if they're brand new to methadone before you increase their methadone from 30 to 45 milligrams, let's say. Next slide. Okay, how do I manage the common side effects of methadone? Methadone, being an opioid, has opioid-related side effects. So these include sedation, constipation, sexual side effects, decreased libido, sweating, and dry mouth. I saw a comment or a question about that in the chat, so we can address that here as well. First, you want to determine if the symptom is related to methadone. That actually could require you getting labs. You can't just assume that something is a side effect unless it specifically was linked to occurrence with a dose increase or starting it. So generally, you need to get to some labs to see if anything else is going on. You also want to talk about their health history. So other medications, for instance, not just prescription medications that may have been started recently, but other meds, over-the-counter medications, natural products that they may be taking that could be impacting this, and they just don't know that it is. Other life changes, whether it's a work change, a sleep change, relationships, diet, all can impact things like your sexual side effects and your constipation. If you are determining, yes, this is a methadone side effect, more than likely, and if the patient is stable, you could try a dose decrease and monitor for effect to see if it's going to improve that side effect for them. You normally want to look at a decrease of about 5 milligrams every 1 to 2 weeks, watching that they don't lose stability, so they don't have return of cravings or withdrawal symptoms or return of use if they weren't using, and that the side effect goes away. if someone's just not stable enough for that, you don't think or they don't think that they're going to be able to tolerate that dose change, that's when you would get to the, although unfortunate, management of a side effect with another medication. And we all know that we do see patients in this category, unfortunately, but a lot of opioid-related side effects do have some um, symptomatic treatments that you can give. So something like PEG, an antiemetic, an alpha agonist, or an anticholinergic could help with any of the side effects that I listed. Okay, next slide, please. So now we will go over to the questions that were asked. I did see the question in, oh, you know what? Maybe it was in this chat. I'll have to go up before I screen share. See everyone's answering the questions as well, which I really appreciate. Thank you. Oh, it was just about the, yes, is it standard of care to have point of care testing in the clinic? Mel, did you want to jump in on that question?
Yeah, I think it is. I think that the problem if you send a patient, if you send the urine sample to the lab, you'll get a result, whatever, 2 weeks later. It's not so helpful clinically. It's best to do something in the lab, I mean, in the office right then and there, and feed that back to the patient. You may want to do confirmatory chromatography testing, just to, especially if there are legal issues like child protection, or driver's license at stake. But otherwise, I think it's better to have point of care testing if you can.
Yeah, that's a great point for sure. And unfortunately, I think that ties into um, maybe one of these questions on here, we can just segue over to it. You can continue to submit your questions if you have more, but one of these is, how do you mitigate risk during methadone inductions in settings when a UDS is not available? Thinking about the virtual care settings and outreach vans, which is a great question. So maybe addressed a little bit already, but to highlight, yes, I do work in a virtual setting entirely, and I have started methadone in this setting. So no, I don't always have a urine drug screen in front of me. That comes with a lot of documentation. Best practice is definitely going to be having that urine drug screen because someone may think they know what they're using. They may feel really confident in that. And very unfortunately, sometimes they aren't being exposed to what they thought they were, which could put them at risk of having lower tolerance than reported and us actually causing a methadone toxicity. Unfortunately, there are real world case reports of exactly that happening and patients dying. So it is a real risk, and it would not be wrong to say that you need to or you want to have a UDS done before you're starting methadone. That being said, I think it's also appropriate to get as much collateral information as possible from that patient and start methadone at probably not the high dose recommendations. We're not starting 40s or 50s most of the time virtually unless you really know that patient well without the urine drug screen, but the basic starting doses with collateral information. Do you know the patient? Have you been the prescriber of methadone before? Are they reporting that they came from an OATC clinic or a different addictions clinic where you could call them and find out their last dose that they were on and when they took it? Were they recently in hospital? And are you a lucky duck that has access to hospital records and you can look those up or request them? Even with those things, although there may be a delay, a lot of it we can generally get that information by the next day. So it wouldn't be a huge delay in treatment if you really feel that you can't go ahead. So yes, I do start methadone through virtual care with as much information as I can get. But that case example also highlights that there are times I have told people I am not comfortable if something in their story is just not adding up. I can't be confident in their tolerance, in their history or exposure to methadone in the past. I just won't do it for safety reasons. I usually would offer buprenorphine or coming back another day. Okay. I can't see the chat right now. So if there are other things, Mel or Lori, please feel free to let me know. Okay, this is a great question. What is your response to patient concerns of methadone mouth? Mel, do you want to go first?
I think it is a real thing. I think when people swallow methadone, oh shoot, now I don't remember. It's an increased production of saliva, which causes this increased dental caries. Other than, I cannot think at this time of specific.
That's okay. I just put
Uh,
in the chat. So if you look through, because I love this question because we get this question a lot. If you look through our methadone guidance document, we do have a very small section on methadone and dental care because it is a very complex topic. And you'll also notice that we have one reference for it. The reference, if you look into it, only has 17 patients. So can we confidently speak to what we do and don't know about methadone mouth? I mean, no, we honestly can't. But even that reference will highlight that, yes, we know dry mouth is a consequence or a side effect of opioids, not just of methadone. People that are on methadone have been on opioids, usually for some period of time beforehand. That already puts them at risk of caries. So they already could be at increased risk. And one of the things you want to coach about is good dental hygiene and trying to have moisture in your mouth. So having water bottles to sip. The other interesting thing that the reference highlights, which I think is neat, is that people that are on methadone consume more carbohydrates, which is a huge bonus for a lot of our patients that need to eat more regularly. So huge win. And yet that alone comes with an increased risk of dental concerns. So kind of catch 22 there. So complex issue. I never have a straightforward answer in clinic. Mel, what do you say to patients when they ask about it?
Oh, I think it's something that is asked about usually when the patient is a bit on in their methadone treatment, and then I just encourage regular dental care.
Yeah, that's totally fair. And what about the sugars in the drinks? That's a great question as well. Good recommendation to have something to wash back with afterwards, and definitely rinse if you can, or do a quick brush. I actually have recommended people bring their own water bottle with them to the pharmacy as well so that they can have their drink and then use the water bottle as well right after. One of the other questions, I'm curious about the higher dose methadone start. Is this guidance making consideration for contamination of other substances in fentanyl, like bromazolam, that they are not aware of, for example? Great question. That may be one, Mel, unless you want to address it now, that we are going to be doing the Beyond Basics, aka advanced level of methadone care next month. So definitely sign up for the webinar. But Mel, do you want to go for it now?
I would say that the presence of benzos like bromazolam are very common. Often patients don't even know that they're there. I don't think that it should mean that you should lower the starting dose of methadone because an effective methadone dose will mean that they're using less fentanyl and therefore less benzos. However, you need to be alert to the possibility of benzo withdrawal as they decrease their fentanyl use. And that would mean the emergence of symptoms often 2 to 3 days after their last fentanyl use that may indicate withdrawal, such as anxiety, insomnia, that won't respond to methadone dose increases. It's very hard to distinguish sometimes, from opiate withdrawal. But if you do suspect benzo withdrawal, then you can start a taper with clonazepam or diazepam to relieve the withdrawal symptoms, and that might be one way to approach it.
Great, thanks, Mel. Next question is, what is the demographic who may be seeking diverted methadone? Great question. So I don't have a reference at the top of my head for this one, but quickly thinking of who are people that generally could be using a diverted methadone are going to be, unfortunately, some categories that fall into youth, someone that doesn't know or understand the harms potentially associated with it and are being told that it is just an opioid that is going to cause positive effects. It could definitely be someone that is seeking methadone treatment or wanting to get out of withdrawal. Unfortunately, there's still going to be the risks there that they don't know the dose of methadone that they're taking, and they haven't been assessed for their own risks for toxicity and for tolerance, not to mention other drug interactions for how they're going to respond to that dose. And diverted methadone doses can make it actually, unlike buprenorphine, I would say. When someone comes in and said they've taken buprenorphine, it does not hurt my examination or start of buprenorphine. It might make my start of buprenorphine easier. Whereas if someone comes in and said they've taken someone else's or they've just had some methadone along the way, that can make things more complicated in terms of the accumulation of methadone over time not knowing how much they've had and how they're going to respond to the lower dose that I'm probably going to have to give them to make sure that we don't end up with a toxic event. Mel?
Yeah, I think the main sort of demographic is people who are friends or of methadone users. The methadone user may feel, well, look, the 100 milligrams makes me feel great. Here's something that can relieve your opiate withdrawal. I think the main use of diverted methadone is not necessarily to get high, but to relieve opiate withdrawal without realizing the tremendous danger that 100 milligrams in a highly tolerant person is not the same as 100 milligrams in a methadone naive person. So it's important to tell all patients the dangers of letting anyone use their methadone dose.
Yeah, absolutely. This question is, our urine drug screen strips test for EDDP, which is methadone metabolite. We didn't go over that. Apologies on a test strip, but not for MTD or methadone specifically. If prescribing methadone, is it recommended that we test for both the substance and the metabolite? Mel, thoughts?
Um, if EDDP is present, the patient has taken methadone. So you don't need to test for methadone. It's very specific to methadone. Uh, on the other hand, if methadone is present but not EDDP, the patient could have added methadone externally to the urine sample. So I would say that EDDP is good enough.
I would as well, actually. I'm not quite sure if anyone has other situations or examples where the difference of having them or not, the methadone to the EDDP comes up, let us know. I can't think of anything right now. Next question is, what about Bup XR to methadone? Is that also easy? And how is it done? I'm assuming this person means in terms of converting one to the other. And yes, it is also easy. So when someone is on Bup X, we have a whole section at the end. I want to say it's an appendices. There's a lot of appendices. If you're looking at it, we have a whole appendices on converting between a whole bunch of different things, from one to this and that to that. And this is in there as well. So if someone's on Bup XR and they're going to methadone, then just like moving from Bup XR to buprenorphine, you're going to wait until they start to report any concerns, withdrawal symptoms, cravings, or urges, and then you're going to start on a low dose of that medication. If they've already reached, let's say, steady state, so they've had a couple of injections of Bup XR, then you're going to expect that this won't happen for a while. It might take a month. Might take more than a month. So really, it's going to be patient guided in terms of making sure they come in before they're at any risk, as soon as symptoms present, and you're going to be starting ridiculously low dose and titrating to effect, keeping in mind that they already have an opioid, at least a partial opioid agonist, buprenorphine, on board, so they're not at extreme risk right away. With any conversion, I should say there's increased risk for the patient while they're converting because they're not on a stable anything quite yet. So you might want to think of starting at 5 to 10 milligrams, see how they respond, because you're going to have time to titrate that dose, and it's just going to continue to titrate according to the basic schedule. So nothing too fancy about that one. Good question. Okay. Question. If you do an EKG and QTC is greater than 500, is lowering the methadone the appropriate approach to manage? And if so, how aggressively do you, taper the dose? Mel, do you want to jump in?
Yeah, I think that uh, just because the methadone dose is the QT is 500, I'm not sure if that means they're tremendously high risk. I would lower the dose, but you have to balance that against the risk of the patient dropping out of treatment and relapsing. So you have to be very careful. I probably and make sure that other risk factors such as crystal meth use or medications are looked at. Also, I would consider referring to a cardiologist in that case because you're dealing with a rare but potentially fatal side effect versus the risk of patients dropping out. But often, if the patient has been on methadone for a while, they're often able to tolerate slow downward titrations. Uh, they just don't need such a high dose anymore. So I would definitely reduce the dose, but I wouldn't do it to the as quickly to the point of destabilizing the patient.
Yeah, that's perfect. Thank you. I like the comment that's in there that someone had heard a pharmacist discourage patients from bringing their own water bottle in case they were spitting their water bottle, their methadone into their water bottle. I'm guessing is that situation. Fair point. That's really unfortunate if that's happening, and hopefully it would be caught. I don't know if that's a good enough reason to discourage everyone from bringing water bottles, thinking they're diverting it, but something to consider. The other one is that pocket toothbrushes are so affordable and easy to find, and might be something that your clinic could offer as a harm reduction strategy that someone could bring with them to just rinse their mouth or their teeth quickly after they consume their methadone. Okay, that's it for the Mentimeter questions. I'm going to come back to our questions in the chat box, make sure I'm not missing any, as I think Lori's given us the 5-minute warning here. A comment about some false positives with EDDP in the past. Sorry, Lori.
Go ahead.
I am hearing you on the 5-minute mark. Okay. Let me know if I've missed your question. I'm going to go through them quickly. Yes, we do have another webinar. Please feel free if we've missed your question or comment to join the next one. For the question that we received about a couple of times about benzos in the fentanyl, definitely come to the next webinar. We'll make sure that we're addressing your questions for sure. Thank you for everyone that responded for what a point is. Appreciate that. Oh, right. Comment about methadone liquid sometimes is not accessible in the emergency department setting because pharmacy can be unavailable for mixing, such as late evenings. Good point. This person says they tried a couple of times of using methadone tablets. Mel, maybe you want to talk to this. They say it worked well with their patients, but they're just wondering if this has ever happened to other people before to use the tablets.
If the methadone tablet is observed, if the nurse watches the patient swallow the methadone tablet, that seems reasonable to me. I think the other thing is to make sure that the emergency department has methadone stock doses on site, so they don't have to call in the pharmacist at midnight to come in and mix it up. I think that's important. The Center of Excellence has determined that methadone is a medication that should be available in all emergency departments, and they are working towards that. So that would mean that methadone should be available in the pharmacy, in the emergency department stocks, not just in the hospital pharmacy. But using methadone tablets makes sense to me as long as the dose is observed.
Yes, and obviously that question comes for hospital because there's also concerns in the community about coverage for those tablets.
Yes.
Sorry, Mel, go ahead.
Yeah, methadone tablets are very pretty expensive, and they're not covered by ODSP. I think they're mainly covered and used by palliative care doctors because methadone is an very effective opiate analgesic. But yeah, they're very hard to get coverage for in the community.
Okay, I hope we got to everyone's questions. I will flag to the team that MTD versus EDDP for our next conversation, as well as the benzos and fentanyl. So they will be addressed for you at the next chat. And thank you so much for everyone for your comments and questions here and participation. There was a link shared in the chat for our evaluation form. It means so much to us if you're able to fill that out and just let us know what you're thinking. And please reach out. Mel mentioned having a mentor or someone that you can call on is very important while you're getting started with methadone. There's a whole list of people here that you could potentially reach out to. The Medify listserv is another good spot to post your questions, as well as the Addiction NP listserv. And our team, the Medify team, is always happy to help put you in touch with someone with a little bit more experience if you do need to call anyone with a question, if you're feeling uncomfortable getting started. Otherwise, thank you so much, Mel. Appreciate it. Thank you, Lori. Do you want the last words?
Just to say thank you. That was fantastic. 8:30 on the nose to everyone who could stay until the end. Keep the questions coming because Mel and Katie both love to engage with this topic. And look at the resources on our website. Look at the next webinar on our website to sign up and go from there. Thank you so much. I'm going to stop recording.
Thanks, everyone. Have a good night.